DES, which was not a good thing, was developed. And then in 1941, FDA approved estrogen to treat the vasomotor symptoms of menopause. And then in 1942, Premarin was born. And it is the extracted from pregnant mare's urine. That's how it got its sweet little name. And then in the 50s and 60s, lots of people started using hormone therapy. And it was beginning of the women's movement. One guy who wrote a book that a lot of people were following at the time was talking about the tragedy of menopause, destroying her character as well as her health. Man, we got nailed. And then in 71, they realized, DES has some pretty bad side effects. And 4 years later, they withdrew its approval for use during pregnancy. It had been used to give to women to support early pregnancy in women who were, at risk or had miscarried a lot. But then they found out that it was causing bad stuff, so stopped it. In 75, they finally realized that estrogen was increasing uterine cancer. And then in 76, they realized that it was linked to breast cancer. And then in 1979, which wasn't so long ago, there was the debut of combination therapy to protect the endometrium. And then in 85, this big nurses study came out, and everybody was so excited because it showed that estrogen users had 40 to 70% decreased risk of coronary artery disease. But it also showed that there was a 33% increased risk of breast cancer. And in 1992, most of the big organizations were recommending long-term use of HRT. In other words, women into their 80s and whatnot. So as you can see, the American College of Physicians said all women should consider preventative hormone therapy with 10 to 20 years for maximum benefit. An ACOG technical bulletin from 92 said that HRT, not suited to everybody, but it confer health benefits, enhance quality of life, and prolong life expectancy. That's a big one. And then we come into the Women's Health Initiative study, which was launched in 93, big long-term NIH study. And it was actually not focused so much on does HRT cause breast cancer and yada, 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 but it was focused on disease prevention in healthy postmenopausal women. So there were a bunch of different trials. Some were how do women respond with calcium supplementation, or if they're on hormone therapy. And the trials were designed to, some of the trials were designed to assess the effect of hormone therapy on the prevention of heart disease, breast, colorectal cancer, and osteoporotic fractures. And they used the most common preparations at the time, and they're probably still the most common preparations, which is Premarin and Provera. They had two arms in the hormone therapy studies, the estrogen and progesterone arm, and like 16,500 women, mean age of 63, but you can see that spans a big age range from 50 to 79. So they were randomized to either Premarin, 0.625 with Provera, so a continuous combined, or placebo. There was a mean follow-up of 5+ years, and it was stopped a couple years early because it reached the threshold of clear harm that was seen by an independent safety advisory board. They saw an elevated risk of breast cancer, coronary artery disease, stroke, venothromboembolic events, and it outweighed the benefits on hip fractures and colorectal cancer. So if we look at the results that came out with that initial publication of the WHI, you can see that coronary artery disease was increased by 29%. Strokes, thrombotic, were increased by 41%. Venous thromboembolic events were increased by 113%. Breast cancer by 26%. Colorectal cancer was actually decreased by 1/3, along with hip fractures. So if you look at the absolute risk for every 10,000 women taking combined estrogen and progesterone, 8 more will develop invasive breast cancer per year, 7 more will have some kind of a cardiac event, 8 more will have some kind of a thrombotic event, 8 more will have a stroke, 6 fewer cases of colorectal cancer, and 5 fewer hip fractures. So it doesn't look so good. And then if we put the WHI risks into perspective, you can see the relative risk and the absolute risk of the estrogen and progesterone, and on the far right, the estrogen therapy alone. And there's a big difference here. If you look at the estrogen and progesterone, coronary artery disease, there were 7 more with estrogen and progesterone, but 5 less with estrogen alone. Strokes, more. Thrombotic events, more. Breast cancer, 8 more with estrogen and progesterone, but 7 less with estrogen alone. Colon cancer, 6 less. Hip fractures, about the same. So the estrogen alone arm was about just shy of 11,000 women. Again, same age range. They'd had a hysterectomy. They didn't need progesterone, and they were randomized to placebo versus Premarin 0.625. This was carried on longer than the estrogen progesterone arm, but it was stopped 1 year early because it reached threshold of clear harm. They did see an increased risk of stroke that we saw before, and they felt that it was not acceptable in healthy women in a research study. Estrogen alone did not appear to affect either positively or negative, so neutral heart disease, which is a key question of the study. And if you look at the estrogen alone arm, you can see the stroke is still elevated, venothromboembolic events still elevated, coronary artery disease neutral, breast cancer decreased, colon cancer neutral, and hip fracture decreased. So again, the absolute risk of these women taking estrogen only, 5 fewer will have an MI, 12 more will have a stroke, 7 more will have a venothromboembolic event, 7 fewer will develop, pardon me, invasive breast cancer, colorectal cancer is neutral, and 6 fewer will have a hip fracture. So everybody's always worried about the breast cancer risk with estrogen, but you got to take into account what you're seeing here. So this is then after the initial publication where everybody threw up their arms, women were calling the offices. It was pretty amazing, saying, I want off hormones, and now I'm having hot flashes. What do I do? Yada, yada, yada. It was kind of a crazy time. At that point, the same researchers started to tease out different things about their initial publication. And they started looking at age and time since onset of menopause and the bad things that they were seeing. So you can see in the younger age group, 50 to 59, the relative risk of coronary artery disease was pretty neutral, and the same with the less than 10 years from menopause. As you go up in years, you can see that your risks really increase. And if you look at a 70 to 79-year-old who's been menopausal for more than 20 years, if you start her on estrogen because of hormone replacement therapy, that's a big risk for her. With the estrogen alone, they also started teasing out the ages. And as you can see on the left, the 50 to 59-year-olds, you don't really have to worry about coronary artery disease in starting women on this. It shouldn't be part of your evaluation for an appropriate candidate unless they've had something like pre-existing coronary artery disease, MI, blah, blah, blah. So they came up with now what's famously called the timing hypothesis, and that's where the effects of hormone therapy on coronary artery disease vary depending on age and time since onset of menopause. So women who are younger than 60 or within 10 years, reduced coronary artery disease. And again, if you're starting somebody who's 10 or 20 years out from menopause, increased risk of coronary artery disease. So these are the absolute risks by age. In the 50 to 59, you can see it's pretty low. It's a decreased coronary artery. You know, that stroke thing is still really a big thing. And if you swing over to look at the 70 to 79-year-olds, so we really have no business starting people of that age. So this is just, you know, they're like, why is this happening? Well, women who are younger than 60 or within 10 years of menopause, they've had this wonderful benefit of estrogen for so many years that they've had the vasodilation, decreased inflammatory activation. But once they're older and they haven't been on hormone therapy, then you get into adding to plaque instability with decreased vasodilation, increased inflammatory activation. So then we go on to the whole thing of breast cancer with estrogen and progesterone and estrogen alone. And as you can see, estrogen alone across the board is decreased, estrogen and progesterone. So there must be something with that Provera. Who knows? Anyway, they didn't see an increased risk of breast cancer until approximately 4 years of hormone use. So when this all came out, then we were all saying to women, okay, you can take hormone therapy, but you know, let's cut you off at about 4 to 5 years. And then this is just looking at the health risk and benefits 3 years after stopping the progesterone, estrogen and progesterone trial. And especially if you look at like hip fracture, you can see that the benefits really dissipate fairly quickly. Breast cancer is about the same, total cancers, yada, yada, yada. Okay, and that's just kind of about the same thing. So a couple kind of points. So the timing hypothesis, age and time since menopause seems to modulate coronary artery disease and all-cause mortality in favor of younger women. In a recently menopausal woman with moderate to severe hot flashes or vasomotor symptoms, concerns about coronary artery disease really shouldn't be a major factor in decision making. And estrogen plus progesterone versus estrogen alone, they have very divergent risks on breast cancer risk. Hormone therapy should not be started or continued for either primary or secondary prevention of coronary artery disease. If a woman's not symptomatic, don't initiate treatment because there's still potential for serious risk, strokes, the thromboembolic events. And that is really the biggest problem in both arms. Approximately 50% of the strokes are thrombotic. So adding up a stroke, PE, DVT, there's obviously a problem with thrombosis and HRT. And if a woman only has urogenital symptoms, consider just using local therapy only. And the length of hormone therapy, really, there's no definitive answer. So earlier on, after the WHI, we used to say the lowest dose for the shortest amount of time. So we're not going to say that anymore. Okay, so then we get into treatment. So FDA approved indications of hormone therapy. First-line therapy for bothersome vasomotor symptoms in postmenopausal women who don't have contraindications. Primary therapy for prevention of bone loss and fracture in women who have an elevated risk of osteoporosis or fractures. A very important thing is that sometimes we forget about is it's also for hypogonadism, premature ovarian failure, premature surgical menopause. You take ovaries out in a woman in her mid-30s, 40s. Hormone therapy is recommended until the average age of menopause, which is 52. And they've done some studies that show that instead of putting people like on low-dose birth control pills, that actually hormone therapy has more bone protection, which is kind of funny because it's a lower dose of hormone. And then vaginal estrogen is recommended as a first-line therapy if a woman just has isolated urogenital symptoms. Contraindications, current, past suspected breast cancer, estrogen-sensitive cancers, undiagnosed vaginal bleeding, previous or current unprovoked a venous thromboembolic event, a recent arterial thrombosis, untreated hypertension, active liver disease, hypersensitivity, and porphyria cutanea tarda. This is kind of a sample of what our patients get for any estrogen preparation that they give them. In 2003, the FDA said, oh, anything that has any estrogen, it has to come with a black box warning. So they will frequently go home and they'll read this and they'll say, oh man, I'm going to get dementia, I'm going to get malignant breast cancer, I'm going to get cardiovascular disease. And it's still mandated. So then we get into this whole thing of you have somebody that you're thinking that you want to put on hormone therapy, and they say, well, doctor, I want to be on bioidentical hormones. So bioidentical hormones are plant-derived hormones that are chemically similar or structurally identical to those produced by the body. Bioidentical hormones is really a marketing phrase more than anything. They want a woman to feel like, oh, she's just getting the most natural stuff in the world, plant-derived, yada, yada. But compounded preparations haven't undergone any rigorous clinical testing for safety or efficacy. So, there's no FDA oversight. So if you're writing a prescription and they're taking it to a compounding pharmacy, you're not really sure of what they're getting. And the most important thing is there are many FDA-approved bioidentical hormones. And it's kind of funny because any compounded hormone therapy things that a woman would want, they are plant-derived, but they still, it's the same base product as the FDA approved, and they go through all the other production and manipulation to get the stuff that they're going to use in their compounded creams or whatever you want. This is just a complete list of all the different oral estrogen products. And Premarin, which is not bioidentical, I marked with a little red the things that are bioidentical. Premarin is the favorite of the county. If you can, try to use estradiol, but it just depends on somebody's insurance coverage. These are all of the transdermal things. We have patches, we have gels, we have emulsions, we have spray, we have rings, we have a whole lot of stuff that we can use. This is now a combination therapies. So a woman who still has her uterus, remember she has to be taking progesterone for protection. And it's an interesting point because unopposed estrogen use in postmenopausal women, there can be a very quick, like within 4 to 6 months, turn from, a normal atrophic lining to a cancer. Now it's usually longer than that, but it can be a quick change. Yeah.
As far as insurance coverage goes,
yeah.
I'm just curious, like, if you're just comparing synthetic to bioidentical, are those covered differently? Like, if you were to take like Suarez versus like Premarin?
No, it's simply what they decide they're going to cover and what's in their formulary. And everybody, as you're well aware at this point in your training, has a different formulary.
Yeah.
Yeah, everybody does. But Premarin is kind of the big one. It has the biggest market portion, and it's the best known, etc. But it's not bioidentical. So if you look at your different estrogen preps, pills, they're familiar, it's discreet, it's usually the least costly. Cons, first goes to the liver, first pass liver effect, increased triglycerides, increased CRP, some GI side effects, and then you get into the increased risk, MI stroke, yada, yada, yada. Patches, which I try to encourage all of you to go to first. There's no first pass metabolism, so there's less impact on clotting factors, minimal effect on triglycerides. Lots of options. The cons, sometimes patients are allergic to the adhesive, and it'll leave a real bright red mark, and it'll be itchy and whatnot. And they go, oh, I take it off, and I put it on, and then all my clothes, that get a little lint ring, whatever. And some of them just are poorly made and they fall off. A good patch should be able to be worn in a hot tub, when you're swimming, when you're at the beach. And then lotions and gels, pros, same as patches. Cons, you can get inadvertent transfer of cutaneous estrogen. I don't know, I think that's pretty darned rare. So progestins, if a woman has a uterus, you got to protect it. Unopposed estrogen is associated with an increased risk, relative risk 2.1 to 5.7 of hyperplasia or adenocarcinoma. So what are you going to use? Oh, this must have been in the wrong spot, but these are estrogen dose equivalents. People are always asking, if I'm giving 0.625 of Premarin, then what does that equal for estradiol? So standard doses, Premarin 0.625. Estradiol is 1 milligram. The transdermals are 50 micrograms of estradiol. Low dose preparations, usually about half the standard dose. And very low dose is usually just used for the treatment of urogenital atrophy. So these are all the different progestogens that you can use. And we usually are stuck with Provera. If you can use Prometrium, which is a micronized progesterone in peanut oil, so can't use it with somebody with a peanut allergy, that is a bioidentical hormone, and it has much fewer side effects than Provera. You can also use a Mirena. So why use micronized progesterone instead of Provera? Synthetic progesterones have been associated with a lot of metabolic vascular side effects. Women just feel crummy. Disturbances of lipid levels, glucose metabolism, suppressing the vasodilating effects of estrogen. Not to mention that if you look at the 2 studies looking at breast cancer, the study with estrogen and Provera, with Premarin and Provera, there was an increased risk of breast cancer. If you cut out the Provera, there wasn't. They usually have just bad side effects, you know, you feel bloated, weight gain, acne, headaches, mood disturbances, breast tenderness, blah, 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 blah. Micronized progesterone, which is marketed as Prometrium, has been used widely in Europe since 1980, well tolerated, minimal to no change in lipid profile, blood pressure, or carbohydrate metabolism. We think it's probably less thrombogenic than other progestins. And the only real side effect of Prometrium or the micronized progesterone is you might feel a little drowsy, and so you just tell them to take it before they go to bed, which is nice. It helps them sleep. You can also use a Mirena. It's off-label use. It has been used in Europe for many, many years, and it provides really high intrauterine but low systemic concentrations of levo. And for women who can't tolerate oral progestin and need that protection, it's a great thing to do. Data with the Mirena showed as good or better than systemic progesterone in preventing hyperplasia. Limited data for the smaller levo IUD, but in 2 small studies, they didn't see any hyperplasia or anything more than that on endometrial biopsy. And it might be a good idea to use the smaller one just because a postmenopausal uterine cavity is going to be a little smaller. You can also, for women who can't tolerate progestin, you can use, Duave is what it's marketed at. It's bazodoxifene and Premarin. So when you see CEZ, it's conjugated equine estrogen, that's Premarin. It's progestin-free. Bazodoxifene's a SERM. You can treat vasomotor symptoms, preserve your bone mineral density, protects the endometrium, and does not stimulate breast tissue. And you get really good, nice, high rates of amenorrhea. You're going to be limited in using that simply by cost and by coverage. Very few insurance companies will cover it. So how do we optimize the safety of hormone therapy? Are transdermals, non-oral estrogen preparations safe? We think so. They certainly expose the liver to lower levels of drug. then do your oral preparations. And remember, with your orals, you're getting that first pass effect. So you're increasing your procoagulant factors and decreasing your anticoagulant factors. So transdermals appear to not affect the coagulation system, but there's kind of a lack of big comparative RCT data. So that kind of limits our preparation, but a myriad of small little studies looking at it say, oh yeah, that it does decrease the risk. And if you think about it, the risk of stroke and thromboembolic events, that's the biggie. So if a woman has isolated urogenital atrophy, and that's something that you should always ask about, it increases with age from about 50% of women in their early menopause to about 75% of women greater than 70. So because it's a progressive change, it just keeps getting worse, generally speaking. Treatment is long-term, so I just usually tell my patients this is a forever prescription because symptoms will almost always recur after cessation. And it's important to reduce your systemic estrogen exposure to the lowest possible extent because we're giving it to women over such a long period of time. These are all the different options that we have to give. These, except for the Premarin vaginal cream, these are bioidentical because they're estradiols. The one that people tend to like the most is the pill, the vaginal tablet, goes by Vagifem. And when you're starting somebody off, if your patient is really symptomatic, then it's nice to give them a little burst dose. And I usually do that for 1 to 2 weeks. I'll give them a daily dose for 1 to 2 weeks, and then I'll have them cut back to the twice weekly dose. And this was kind of a cool little study. It looked at the annual delivered dose of estrogen, the serum levels and whatnot. A couple things are missing here, but the vaginal cream was the bad one. The maximum annual delivered dose of 7.1 versus your 10 microgram Vagifem tablet. And I think that's probably because it's really difficult to describe to patients how to use a vaginal cream. And they'll go home and they'll fill the entire applicator full and they'll insert it, and they may be using it every day, or they may be using it when they're having sex. So that's always a real important thing. Patient education on how to use that is super important. And typically, they're going to be using 1/4 of an applicator 2 to 3 nights a week for maintenance dose. So used to be lowest dose for the shortest time, and now it's the appropriate dose via the appropriate route for the appropriate length of time. Okay, so then we're going to go over some little case reports. I hope I can do this. Okay, so I want to new screen. I'm going to X out of this. Okay, and I want to go to a new share, and then I want to go to cases. How do I get out of it? Just click on that. Yeah. Okay. So there's about 6 or 8 cases. I can't really remember. So we'll just discuss. Go one by one. Oh, I can't do that. Okay. So case 1. So you got a healthy 43-year-old woman with a uterus who began having severe vasomotor symptoms that were affecting her quality of life, and non-pharmacologic measures failed to control her symptoms. Would you start HT people in here? Yeah. That's a decent idea. All right. If yes, which therapy would you consider as primary therapy? You have to pick one. Systemic combination, transdermal gel, emulsion, yada, yada. Low dose vaginal estrogen, progesterone only, or birth control pills. What do people think? Michelle, what do you think? Well, that's kind of a good thing. Oops. What did I do here? Sorry. Okay, so you can go with either systemic oral or systemic combination. Of those two, I would start with the patch, okay? So there's no contraindications to starting hormone therapy. A and B would be reasonable. Both are equally effective. Transdermal is as effective for preserving bone density, but then you get into the whole thing with the stroke and the VTE. And it has, transdermals obviously have less of an effect on serum lipid concentrations. However, if they don't want to use patch, if they say, oh, I don't like that, then, you know, just go with oral. And this is the really interesting point that birth control pills suppress the ovary, and despite the high doses of hormones, have shown not to be as effective on bone health as using hormone therapy. Okay.
Maybe a silly question, but how do you use an emulsion? What is an emulsion?
Oh, they come with, they're like metered. They have these weird sprays. Some of them look like a big, it's like putting a suction cup on your arm, and it'll deliver a dose, and then you rub it in. So there's sprays that you just push, rub in. There's emulsions. They give you the doses are set. Yeah. But then they're only estrogen, and so you have to add in a progesterone. So take-home points, hormone therapy in premature menopause. In women, data regarding hormone therapy in women over 50, don't extrapolate those to your younger women. Especially don't apply the WHI bad results. Observational studies suggest that benefits outweigh the risk for bone, heart, cognition, urogenital atrophy, sexual function, and mood. And you want to continue until at least the median age of menopause. You may want to give them a little bit higher dose than 1 milligram of estradiol. You might want to put them on 2 milligrams of estradiol. But you want to have them on hormone therapy. So don't forget that in terms of your patients who you're taking to the OR or who go through ovarian failure. So case 2 is a 43-year-old woman with the uterus. Began having severe vasomotor symptoms affecting her quality of life. She was started on combination, and she continued for 10 years. Good results. So now she's 53. She tried to wean off, but everything came back. She'd like to continue. What do you think? Do we let her? Huh? Yes, ma'am, you can. Yes, you can, absolutely. If yes, and it is yes, which therapy would you consider primary? Select the best possible choice. What do you think, Camille? B, yep.
I think you could continue her on the patch therapy if she's having good response to it.
You're correct. Okay. So use an appropriate hormone therapy type, dose, formulation to meet your treatment objectives. And then what you want to do, what's that?
I think you thought you must have said meal. Instead of the meal, I think you thought you were talking about
Oh, well, anyway, that was the right answer. But it, you know, once they get, you know, into, you know, their mid 50s, you know, you want to readdress this every now and then. Okay. Continuing hormone therapy is a reasonable option, but you can counsel her about non-hormone options, see if she would prefer this. And if she wants to continue, put her on the transdermal. It's just going to be better overall for her. So this is that patient with premature menopause. She started hormone therapy at 43. She continued at 53 after she tried to wean off. So now she's back. She's 60. She went off hormone therapy for 6 months, and she tried all sorts of stuff, low-dose antidepressants, gabapentin, acupuncture, hypnosis, but her hot flashes and night sweats just wouldn't leave her alone. She's miserable. She wants to restart. She has no major health problems. Okay, so what would you do? Would you just say no, because she's over 60 and more than 10 years from menopause? B, tell her that her risk of blood clots and stroke is the same regardless of dose and whether she takes transdermal or oral. We know that's not true. Resume hormone therapy with low-dose transdermal estrogen and oral micronized progestin. Describe compounded transdermal estrogen and progesterone therapy as it has no known risks. We know that's false. And E, have an informed discussion about the risks and benefits of extended duration of hormone therapy use, including potential breast cancer, stroke, and all the bad stuff we were talking about. There you go. Correct answer, E, talk to her. Offer other therapies, but you don't want to force things down her throat. And if she wants to restart, and she really feels strongly about this, then you're going to want to put her on a transdermal with micronized progesterone. Would be a safe choice if she decides to continue. In general, you don't want to do a new initiation of hormone therapy after age 60 or more than 10 years of menopause. Because it really, at that point, a woman should have gone through, quote, the worst of her vasomotor symptoms. And so you kind of have to question, now, why are you showing up on my door? Did you see some ads saying if you take estrogen, you stay young, all that good stuff. And in general, you would not want to restart at age 70 after there's been a gap. Let's say they stopped it and they're, you know, when they were 63, and then they come back in their 70s and say, you know, I just felt so much better on that, doc. Well, you just kind of don't want to go there.
Is there data on like an appropriate gap? Like if they try to go off for a year, is that more acceptable?
That is more acceptable, but there's not a hard and fast rule. Like there's just not a hard and fast rule about how long can women stay on it. As it says here, there's no general rule to discontinue hormone therapy after 65. I don't know what the Beers criteria is, but whatever. Decisions regarding whether to continue hormone therapy is just, you know, between, got to sit down and talk. You've got to appropriately counsel, and you have to do ongoing surveillance. So case 3, 55-year-old, has a uterus, severe vasomotor symptoms not relieved with non-pharmacologic therapy. She has no history of cardiovascular disease, and her blood pressure and lipids are normal. Would you consider prescribing hormone therapy, assuming that you use progesterone? Yes? Do I see heads nodding? Yeah. So, which therapy or therapies would you consider? Low-dose systemic combination, transdermal systemic hormone therapy, low-dose vaginal estrogen, conjugated estrogens plus bezodoxifene. What do you think? Low dose, let's just go one by one. Low dose systemic combination. Yeah. Transdermal systemic hormone therapy. Yeah, as long as you give her a progesterone. Low dose vaginal estrogen. No. Conjugated estrogen plus bezodoxifene. Would you? She's coming to you because she's having bad vasomotor symptoms. Sure, that's an appropriate thing. Okay? So the only one is the low-dose vaginal estrogen. So she's within 10 years of menopause. She has no contraindications. Low dose, let's see, A, B, and D would all be reasonable. Bazodoxifene, it's not generic, so cost. I've never written a prescription for bazodoxifene because I work at the county and nobody would cover it. Remember, it's for women who have an intact uterus. Okay. 55-year-old woman with a uterus experiencing severe vasomotor symptoms, not relieved. She has migraines with ARA, prior history of MI, currently labile, high blood pressure. Don't know if she's taken her meds. Would you consider prescribing hormone therapy for this woman? She's 55. Who would? Nah, who wouldn't? Yeah, you don't want to do that. No. So, she has increased risk of stroke, prior heart attack, yada, yada, yada. Okay, 45-year-old healthy woman with early menopause transition at 39, strong family history of osteoporosis. DEXA shows a HIP-T of minus 2.5. What does that minus 2.5 mean to you guys? Osteoporosis. She has no menopausal symptoms. She's concerned about bone loss and after doing some research is requesting hormone therapy. Would you use hormone therapy for the prevention of bone loss and fracture? If you did, which they're saying you would consider it, which therapy would you consider? Low dose, systemic, higher dose, systemic, low dose vaginal, progesterone only, oral contraception. Okay, A and B, reasonable. Given her young age, she may benefit from a higher dose of systemic hormone therapy, and she'll have additional benefits beyond just prevention of bone loss. If she was menopausal over 50 without symptoms, not everyone agrees with using hormone therapy just for bone loss if the patient is not having vasomotor symptoms. But it is an indication for use of hormone therapy, primary prevention of osteoporosis. So don't forget about that. It very effectively prevents postmenopausal osteoporosis and fractures. Women in the WHI studies had a 33% reduction in hip fracture. But remember, once you stop that, those good effects dissipate very rapidly. Okay, a couple more. Yep.
I'm just curious, like, if somebody is like a primary patient and diagnosed with osteoporosis, do you feel comfortable providing them with bisphosphonates, or do you generally send them also to a primary care provider?
No, I put women on bisphosphonates. Yeah. But then you have to counsel them about how to take them, yada, yada, yada. Okay, 45-year-old woman, past medical history of DVT during pregnancy at 30. She now has severe vasomotor symptoms that are interfering with her quality of life and have not improved. She's tried non-pharmacologic conservative therapy. Would you consider prescribing hormone therapy as a first-line treatment? Harris? Are you sleeping over there?
No, sorry.
Okay. You wouldn't?
I mean,
Why wouldn't you?
well, I think we're about to, definitely it was a little key during pregnancy, but I would still be nervous about their obviously just
I mean, it's yeah, you got to worry about it. Yeah. So if yes, what would you use? Again, I would, okay.
We can consider a low dose systemic one that's transdermal.
Yeah. Or you could just try a non-hormone therapy option. So the best answer is E. try her on something different, not hormones. Given the history of a DVT, if she has persistent symptoms, you can consider hormone therapy. And like you said, you want to do a transdermal and you might want to consult with hemo. A history of a DVT is considered a contraindication when it was unprovoked. And that's not, she does not have an unprovoked thing. Additional therapy. Oral therapy appears to increase. We know that. Lower doses may confer less VTE risk than higher. Yeah, makes sense. If it was a provoked DVT, such as MVA, trauma, pregnancy, and a negative hypercoagulable workup, you can consider low-dose transdermal, okay? If they have factor V, obviously don't do anything. So we know that it increases. I'm trying to see if there's anything. Okay, we've gone over all of that stuff. Okay. Case 7, 50-year-old, healthy woman. She's been reading this Suzanne Summers book. Oh, She's experiencing severe vasomotor symptoms, not relieved with non-pharmacologic therapy. No medical history. She's done a whole bunch of reading on the internet, talking to her friends. She wants that custom compounded, bioidentical, non-FDA approved. Okay, after discussing options, she still wants it. Would you prescribe it for her? Would you, if yes, would you prescribe? Okay, to anyone, would you prescribe it to anybody who requested it? If patient requests, but only after extensive counseling, that it's not the first choice because of dosing, unique safety concerns about compounding, only after failing a trial of FDA-approved bioidentical hormone therapy, only if there is a need for special dosing or product because of medical need or allergy. No, I wouldn't prescribe. What do you guys think? What would you do? How about you, Camille?
I would talk to the patient because yes, this is something that is not necessarily FDA approved. We don't really know much info about it, so I would go in with the team.
Okay. What do you think? What do you two at the table think, huh?
I would say B. I think probably just because I think patients deserve to be counseled on. That it's not something that we are completely knowledgeable about because it doesn't go through the rigorous.
Yeah. What do you two think over here? Would you do it?
I think we as well. I think it's a element of our shared decision making, right? She knows the costs and the risks, and she is obviously dead set on this review.
Yeah. Okay. There's not necessarily a correct answer here. So they would recommend actually D or E. I would go with you guys. If you have counseled her and she still wants it, then what do you do? She'll go to somebody else and she'll get a prescription for it.
She's probably like, you will counsel her and you will document her counseling, but she will probably still want it regardless of findings. I don't know, just when people are like invested in that much information.
Yes.
Outside sources.
Yes. Yes. You're not going to likely change her mind. So you have to work with her. So then you get into all that. Then you do a spit test and everything out. So unique concerns, we know about that. There's no evidence to support the use of routine serum or salivary hormone testing to measure dosage. Okay, so that's important. Like you have people come in and they're in their, I don't know, late 40s, maybe they're having some symptoms. I want my hormones tested. What would you say to her?
Well, for me, I remember experience like we don't use that as our marker to treat. Because we don't have enough data or know too much in my own experience.
Well, late 40s, what would you do, Paris? They come in, they say, you know, they're still having, you know, periods, but they're starting to have some symptoms. They say, I want hormone testing.
I guess what's what specifically they're looking for, what the their estrogen, and I would also talk to them about not to avoid it, but like basically that they're trying to go on menopause, and there's still periods that we carry menopausal. But we don't necessarily need to do that to just, I don't know,
No.
start therapy
No, you
or
don't.
treatment or something.
Yeah, you don't have to do estradiol testing or FSH testing. It's a waste of money. It's a unneeded blood stick. Menopause is really a clinical diagnosis putting together. And what I try to tell my patients, because you know they can get kind of heated about this. I really want my hormone. I want my hormones tested. So I just say our hormones fluctuate all the time. So if I get your home, I'm getting a snapshot of 1 day, 1 hour in 1 day over weeks. It's not going to mean anything to us because if I tested you in a few days, it would potentially be different. So I try to give them that. It's just a little snapshot picture, and doesn't make me change what I'm going to be doing with it. I think that is it. Oh no, sorry. 55-year-old. Okay, she has a history of invasive ER positive breast cancer 6 years ago. Okay, blah, 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 blah. She had tamoxifen for 5 years. Whoops. What did we do? Okay, so. Okay, I don't want to do that. I have an Apple laptop and I can't stand this thing. Okay, her hot flashes, they're horrible. She comes to you requesting help. What would be your first choice to help relieve this? Okay, so now we're gonna go. Yeah. Yep, you got it. So women are gonna have more hot flashes when they're on tamoxifen. Remember that. And when they're on aromatase inhibitors, oof, because that drives your estrogen line into the negatives. So they're going to be very symptomatic, and the urogenital atrophy symptoms with that, with tamoxifen and with aromatase inhibitors, can be horrible. So keep that in mind. And how are you going to treat them? Okay, and I think this is it. Oh, no. Okay, so if they absolutely push for stuff and you can't find anything that makes their quality of life worth living, talk to your oncologist. That's it. Woohoo. Questions? Nope. See what they say for 7.